Good morning and welcome to the 8th meeting of the Health and Sport Committee in 2021. We have received apologies this morning from Alex Cole-Hamilton. Can I ask all members and witnesses please to ensure that mobile phones are on silent and all other notifications are turned off during the meeting. The first item on our agenda today is our roundtable evidence session on the current quarantine, travel and accommodation regulation. The purpose of this session is to hear from stakeholders about their experiences of the practical application of these regulations in their sectors and the public health implications of them. We currently have 3 sets of regulations before us to consider: the Health Protection Coronavirus International Travel Managed Accommodation and Testing Scotland regulations, the International Travel Managed Accommodation and Testing Amendment regulations, and the International Travel Scotland Amendment number 6 regulation. Cover a number of different aspects, and we expect to take evidence next week from the Cabinet Secretary for Transport, Infrastructure and Connectivity, Michael Matheson, on these instruments. This evidence session will inform our evidence session with the responsible Minister, and I welcome this morning to the committee Mark Johnson, Chief Operating Officer of AGS Airports Limited, William MacLeod, Executive Director for Scotland of UK Hospitality Scotland, and Professor Devi Sridhar, Professor and Chair of Global Public Health at the University of Edinburgh. Thank you all for joining us today. We will move directly to questions, and can I start by asking, in your view, how important are controls at borders and controls on international travel in tackling the pandemic in relative to other measures that may or are being taken? Can we start, Devi Sridhar? And as I mentioned, I think a little bit earlier, if I can ask other witnesses who wish to answer a question, please put R in the chat box while the first person is answering. Devi Sridhar.
Good morning, and thank you for having me here today. So yes, travel restrictions, we've now had over a year to study countries across the world and see which countries have more successfully suppressed the pandemic, bought time for vaccine rollout and other kind of therapies and treatments, and kind of compare them. And it is clear that no country has been able to sustain suppression without having border restrictions in place. And the reason, quite simply, has to do with the gradient in the world. If you have numbers come down, so your prevalence is much lower, leaving your borders open just means a higher prevalence will come in and then keep kind of pushing you back up. And now we have the additional risk of new variants. We've already seen this week the Brazilian P1 variant, which is concerning. It's not going to undermine our entire vaccine program. Our vaccines are still very effective at stopping severe illness, hospitalizations, but it is a warning of things to come as the virus circulates in other places. So I guess just to sum up Scotland's position is we saw last summer that there's multiple evidence sources that show how low levels came in Scotland. You know, you can look at the evidence around hospitalizations with those with COVID, level of death, case numbers, testing positivity, and then, we've seen the genetic sequencing work comes out, which can actually trace lineages and understand which strains die out and which actually continue. And we can see a lot of reseeding kicked off our second wave. And this is the same thing that's happened in other countries as well. Iceland, Greece. I mean, you can look around at that phenomenon, and we're seeing that continual challenge in Australia and New Zealand, even with their very strict managed quarantine procedures. But I think looking forward, if we do want to protect against new variants, we need to have strong measures in place while we wait for the rest of the world to catch up, or we can start forming partnerships with other countries that have reached similar level of vaccine rollout and similar levels of suppression. So it's a time-limited move to actually do this until Scotland can get ahead of it, get a full domestic recovery, and then while we're waiting on other countries, we have that kind of level of protection that many other countries have put in place across the world.
And in your view, I think you mentioned there will come a time when we need it less. Was there a time earlier in the pandemic when we might have needed it more, and should we have done that? Devi Sridhar?
Yeah, I think now with the clear evidence that's emerged, we were in a very good position in Scotland last June and July. The numbers were incredibly low, and if we had been managed to seal off at that point, I mean, obviously we're not an island like New Zealand, but that kind of idea of actually protections in place, testing, quarantine, managed isolation, we could have probably prevented the bulk of the second wave, because test, trace, isolate works really well when there's low numbers or where there's flare-ups. You can remember the outbreaks in factories, those were quickly contained. Even, the pub cluster in Aberdeen was managed through local restrictions for a limited time, and you could see the numbers came right down. When you start having too many seeds being planted all over the country, then it becomes a very hard proposition to ask, test, and trace to manage those kind of numbers, and you're forced into a lockdown. So that was really the moment. And I think if we look at countries that have built up, coming back to kind of their travel and their tourism, the way they had to go was first deal with their domestic problem, then get their domestic recovery, meaning hospitality, bars, construction, all the things we need for people to be in jobs and for the economy to recover. And then they set up really innovative aviation partnerships. So some of the airlines that are making profits are actually in East Asia because they've managed to have testing and quarantine procedures so it becomes safe. In some way, I think the UK wanted to avoid having aviation and tourism collapse, and so they actually tried to stay open. But the result was they collapsed anyways because few people are traveling, business travel has stopped. We see much lower numbers in aviation anyways, behavior has changed, but we haven't taken the benefit, the public health benefit of stopping new importation of strains and new variants coming in. And so going forward, we're in a good position. I guess looking forward, everyone says, well, how are we going to get out of this? I think if these vaccines stop transmission, which they look like they might, we will reach a stage of vaccine passports. It's already being discussed in the EU. We already have countries like Israel have introduced green cards domestically if you actually have gotten vaccinated. And I think similar to yellow fever, where the WHO has certification if you've been vaccinated, we will reach a state where aviation will continue. And Spain and Greece are really keen on this for their tourism industries, where you will be allowed to fly and we can have international mobility, but only when people are vaccinated and we have that confirmation of that you will not infect others when you travel.
Thank you very much. The new process, there is now, of course, a new process in place after a hiccup or two at the beginning. I guess the question now is the new process working, and do staff in airports and hotels understand the process and what they need to do? Or if we can start with Mark Johnson.
Yeah, well, to be honest with you, when the process was brought in, it was very disorganised and last minute, and probably unnecessarily so. We were looking for a meaningful consultation on its introduction, but unfortunately, with the timescales involved, that couldn't happen. So just to give you an example, the announcement was made on Tuesday, the 9th of February, that the managed quarantine would come in on the Monday. So that was less than a week to go before it was to come in. At that point in time, we asked, was it a consultation? And we were told, no, we were being informed that it was to be introduced. We didn't have anything against it being introduced. It was just the manner of how it was happening. We asked for another meeting to go through the detail, because at that point in time on the Tuesday, there was no detail forthcoming about the process or how it was going to work in practice, and that obviously had challenges. So our first meeting of detail was on the Thursday afternoon, late on the Thursday afternoon, and bearing in mind this is before it comes into play on the Monday. And it became clear at that meeting that it was almost like a blank sheet of paper. There was a real lack of understanding as to how airport processes work and how we would actually get this in properly on time. And one of the examples I would give there is around security clearance. So as you probably know, at airports, there's a very stringent security requirement for staff that work airside, staff that work beyond security, and they have to have had a number of background checks, they have to have had criminal record checks, etc. And that can take anything up to 6 weeks to introduce. So one of our first questions was, how are we actually going to get this in place by Monday? You won't have the proper security credentials. And we were told that there was an alleviation that had been granted whereby the contractor would be able to operate off what I think is called an SIA accreditation, which I think is the kind of accreditation that you get as a bouncer at a nightclub. Now, we were obviously very much against this. It goes against everything we try and do for airport security. So we managed to find some safe workarounds, but we did follow up with the DFT after, and they told us that if we had put this in place, we would have had a deficiency notice. So I think it just typifies the challenge we had trying to introduce this last minute and haste. Now, by that point in time, if I speak for Glasgow Airport and Aberdeen airports, I know Edinburgh still had some international flights, but Glasgow had all the international flights cancelled by the end of January. Aberdeen still had 2 flights for oil and gas. So our primary focus was really on what's going to happen with the flights coming in through the likes of Heathrow. Now, at that point in time on the Thursday, we asked the question, how will that work? Because obviously the Scottish Government policy of a blanket quarantine was different to UK Government policy of red lists. At that point in time, we were told that anyone flying in to Heathrow, for example, would then have to quarantine at that point of arrival before they could then travel up to Scotland. That seemed to change a few times, so that was no longer the case by the Friday. I think there was a number of changes in policy, and then what happened on the Monday was where we discovered the loophole, whereby I think it was, it was in the press about the customers that had flown into Edinburgh and ended up in a hotel, but then subsequently were able to leave within a few days because of the loophole that went against the policy. So I think I'm trying to illustrate, your question was how well is it understood? Certainly for customers, it's very difficult to understand because of the nature of how quickly it was put in without consultation for us. It was difficult to understand, and that led to a number of problems when it was first implemented.
Thank you. And just for clarity, you mentioned a meeting on Thursday when you were, when it was said to you that you could follow a certain route in relation to airport security, which the DFT would have regarded as deficient. Was that suggested to you by Scottish Government transport officials or Scottish Government health officials? What was the route, the source of that suggestion and the meeting you had on the Thursday?
I can't, the call, there was many on the call, but I would assume it wouldn't be the health officials that would have suggested that because it would have been to do with transportation.
Yeah. Okay, thank you very much. William MacLeod.
Good morning, everybody. Thank you for the opportunity to put some views to you as a committee this morning. I think clearly the first thing I would say is that as with many sectors of the economy, the lack of international travel has had a very significant impact on our sector. And really speaking part of our industry, during last year, hotels had quite a bit of experience of remaining open for key workers while other parts of the hospitality sector were closed down. And all hotels that I'm aware of had put in place very well managed protocols to enhance hygiene and customer safety. And there was a good track record of accommodating people who needed to be accommodated last year, key workers, NHS workers, utility workers, transport workers. Indeed, albeit the operation of the hotel was significantly restricted in what they could offer their guests. Really, the introduction of quarantine hotels, I'd certainly agree with Mark that it came about at very short notice. I think my London colleagues were involved with the UK government identifying suitable operators, including those close to or on Scottish airports, and hotels themselves dealt with a procurement contractor appointed by the UK government, and they submitted tenders or expressions of interest against a pretty detailed specification. I think we ended up with 6 quarantine hotels in Scotland, although I understand from speaking to one company yesterday that at least one of these hotels has been stood down. The demand doesn't seem to be as high as was expected. As I mentioned earlier, hotels have put pretty extensive operating and hygiene protocols in place. They're very used to looking after the guests, and really it's probably major chain hotels in the main that are providing the quarantine facility. They have well experienced safety and security personnel. They have standard operating procedures which they've put in place. They've undertaken risk assessments, safety assessments, and their staff were, generally speaking, given the option to opt out if they didn't want to work in that kind of environment. There's testing in place for the staff as well as those who are quarantining. And I think at least one company would have preferred to have had the opportunity and the lead time to vaccinate staff, but of course that wasn't possible, and really it takes 3 weeks for vaccination to become effective. But generally speaking, I would say that the arrangement is working very well. It's involving a very small proportion of our industry throughout the UK and indeed in Scotland. And I think the hotels that are involved have risen to the occasion, and just checking around late last week and earlier this week with companies that are involved, it seems to be going fairly well.
Thank you very much. And may I remind all our witnesses again, feel free to put an R in the chat box if you want to come in to supplement any answer from a colleague. And can I call on Emma Harper?
Thank you. Good morning, convener. Good morning to the witnesses as well. Willie McLeod, you've just said that the one hotel stood down because the demand was less than anticipated. How many people are we talking about that have entered managed isolation in Scotland so far? Is it less or more than what was projected?
Willie McLeod.
I'm afraid I don't have that number. It's not something we've been tracking as an organisation, but I think, as Mark alluded to earlier, the number of international flights into Scottish airports is fairly limited. And I think the anecdotal evidence I'm hearing is that since the quarantine restrictions were put in place throughout the UK, that in many instances flight load factors have been much lower than might normally be expected, even at this time. So I have answer to that. As I'm aware, 1 hotel out of 6 has, and I think that's at Edinburgh, has been asked to stand down, although as far as I'm aware, the arrangement with the UK government remains in place in case they're required in the short term.
Emma Harper.
Hey, thanks for that answer. I hope somebody's monitoring how many people are coming into managed isolation. I know that we've had, obviously, flights and airports and passenger journeys will have been affected. I'm going to go back to, I guess, a consultation process. So this might be a question for Mark Johnston. We know that the regulations were brought in really, really quickly, and it sounds like you're saying that it was basically no consultation, just get on with it. Wouldn't it be part of the process that you would be flagged or aware of this because other countries had managed isolation, Australia, New Zealand, for instance? Would it be part of something that would normally you would undertake, as look at what would happen elsewhere as far as being prepared to at least engage in a process of managed isolation, and then that whole travel requirement that would be required in order to prepare?
Mark Johnson.
Yeah, well, we were aware of the fact that it was going on in other countries around the world. Probably our frustration with the lack of consultation was it was signposted by the government in middle of January, for example, and it was confirmed at the start of February. Now, we don't own the process. This is a process that would be governed by the government. You can't start speculating on a process because there's so many variables you wouldn't know where to start. So what we would have liked is, at the point in time when we knew that it was a serious probability of coming into play, that we could have sat down and we could have started to have that discussion to work out what the process was, who was taking accountability in any part of the process, and how we could make that work smoothly and safely. But unfortunately, when that happens at the last minute, that's a very difficult thing to do. So we're a willing partner, we want to make it work, but the lack of engagement made it very difficult for us and made it very difficult for the customer as well.
Emma Harper.
Okay, thank you, Mark, for that answer. Is there continuing dialogue happening right now then between the Scottish Government and the UK Government, and I guess in other players that are involved? Is the dialogue happening right now in order to manage this whole process? If we're going to continue to need managed isolation, we need to continue a dialogue, I'm assuming.
Mark Johnson.
Yes, well, I mean, the process is essentially set up for now. The contractor's on site. We have an understanding of how it needs to work. As was alluded to earlier, with these controls in place, no one's flying internationally. Certainly at Glasgow and Aberdeen, it's only the oil flights in Aberdeen where there's an exemption there. So we just need to be careful that if and when things start to alleviate, that we can still manage the process effectively with any number of passengers.
Emma Harper.
Okay, no, that's fine. Thank you, Convener.
Thanks very much. Just quickly, Mark Johnson, it was between the period when controls were already in place in January and the period after mid-February when the managed isolation procedures came in, was there a further drop-off in travel, or had effectively all international flights already ceased before this system was brought in?
Yeah, all the flights. Yes, we finished last year with a slightly positive outlook for this year, but obviously things moved very quickly with the full lockdown. In January, we still had some KLM flights to Amsterdam and some Emirates flights to Dubai, but they were essentially finished by the end of January, yes.
Thank you very much. And I call Brian Whittle.
Thank you, Convener. Good morning to the panel. I was going to ask some quick questions around procurement of the hotels and some of the services there. So can I ask you what the experience of the procurement process for hotels has been, and what additional requirements hotels have been required to demonstrate to ensure they can actually deliver effective infection control, and has it been a straightforward process?
Willie MacLeod. Willie MacLeod. I don't know if you can.
Directly involved in the. Can you hear me now?
Well, yes, we can. Thank you very much.
Yes, sorry. I've not been directly involved in the procurement process myself, but I believe it worked through the UK government's appointed procurement agency contacting hotel companies that might have been sufficiently well equipped to deliver this service. And I think one of the overriding criteria would have been proximity to or location within the curtilage of the airport, really to minimise travel. There was, from memory, a 9 or 10 page specification that was issued to hotel companies that were interested in delivering the service of topics concerning hygiene, the protocols that were in place, the service of meals, the specification of the meals that would be provided, how there won't be anybody entering the room to provide cleaning or housekeeping services, but what arrangements would be in place to allow the people who were quarantining to undertake that for themselves. There's handling of soiled linen, there's handling of rubbish that's generated in the room, and there's the protocols surrounding delivery of meals. There were also specifications in there about dealing with the security staff who were separately appointed under a different contract. And indeed, if memory serves me correctly, there was also something in there about dealing with the transport staff who were taking passengers from the airport to the hotel. There may also be something in there about the provision of meals for these staff as well. In many cases, as I said earlier, the hotel industry had put in place COVID safety-related procedures. We ourselves produced very significant manual for all sectors of our industry to operate in as safe a manner as possible. And also in Scotland and the rest of the UK, the entire hospitality industry was working to guidance produced by the government, and we indeed cooperated with the government in the production of that. The cost of quarantine was set by the UK government, not by the hotel companies, and they would have submitted cost estimates or pricing estimates for delivering the service required by the government. That's about all I can say offhand about the procurement process. I understand it worked fairly well, although it was very, very much done at short notice. There was quite a bit of working at pace, as they say.
Thank you very much. Brian Whittle.
Thank you for that rather fulsome answer. I really appreciate it. I think in obviously operating a quarantine hotel is not the norm and must have an impact on the business. I wonder how does not operating a quarantine hotel affect the business? You know, how long are hotels locked into contracts, for example, and would they be continued to be excluding from hosting other guests as and when restrictions are lifted? And how does contracts affect other aspects of COVID-19 business support, as an example? There's a few questions in there I appreciate.
Yeah, I don't know how long the contract actually lasts, but each of the contracted hotels was contracted on an exclusive use basis, and they would therefore not currently be able to accommodate any other guests, and indeed quarantine or managed isolation apart, they were only able, under the current more general restrictions, hotels are only able to deal with key workers and other people in very, very limited circumstances. So moving to operating under the quarantine arrangement would not have affected their current normal business, because there is no normal business. I think when their contract ends, there is a requirement, for example, in the contract, if I remember correctly, that when somebody leaves the room, it has to be vacated for 72 hours before the room is cleaned and before housekeeping staff enter, and then it would be subject to a deep cleaning regime. I can't remember if that's specified in the contract, but it would certainly be covered in the hotel's standard operating practices. So if the quarantine arrangement ended, I would imagine that within a period of 72 hours or maybe a little bit more, the hotel cleaned and could return all operations.
Thank you. Brian Whittle.
Yeah, thank you again. Just a very quick question to finish, if I may, convener. Just wondering what input there has been from the unions with regarding to the quarantine hotels. Have they been involved in discussions?
I'll ask William MacLeod. Yeah, William MacLeod.
I don't know if the trade unions were involved with the UK government. As far as I know, the hotels involved dealt with directly with Department of Culture, DCMS, whatever M stands for, I can't remember, Media and Sport. And I understand also that the UK Department of Health was also involved. Whether the trade unions were involved in these discussions or not, I don't know. Being discussed hotels and any unions they recognise, or any staff association. As I mentioned earlier, certainly one of the companies I spoke to had explained the situation in some detail to staff, and they were given the option of electing whether or not to work in these circumstances. I understand that on average there's about 12 or 15 staff working in the hotel to deliver this service, and the security staff are also obviously there in addition.
Thank you very much. I anticipate we will get that question addressed by Gary Smith of GMB, who had hoped but was unable to be with us this morning. Can I now call Sandra White?
Thank you, convener, and good morning, everyone, and thank you for coming along today. I want to explore slightly more about the contracted staff for security. Now, we know that this has been approached as a four-nation approach, and basically the UK government are the ones that are responsible for the isolation, quarantine and security also in that respect. And I was interested in Mark Johnson when he mentioned the fact that the security accreditation was SIA. You're absolutely right, that is used for bouncers, and unfortunately normally people have to pay for that accreditation themselves in that respect. And also I think it was Devi mentioned the Australian situation, who obviously had isolation and way back in March 2020. Now, there's been a lot of coverage in regards to the security situation in the hotels from Australia. And in fact, when they were talking about in Ireland putting people under security and isolating, Professor Toole in Ireland raised an alarm and said it was entirely inappropriate and Ireland should heed the Australian experience or pay the price by using these types of security firms. And obviously in our country here, due to the UK insisting that we go through that process, it's G4S who are the security people there. And what was said was that they don't get standardised training, they don't get standardised supervision, and they can have 2 jobs or 3 jobs, and it's a disaster. This is from Professor Toole in Ireland, and that's what led to the second wave in Melbourne. So I just wondered if the panel had views on the use of contracted security staff to deliver managed quarantine. As I said here, it's a G4S, which has had quite a lot of press coverage. My local paper, Glasgow Times, had quite a big article in it as well. So I just throw that question out if anyone wants to comment on that.
Mark Johnson.
Yeah, I think the point I'd just like to make, I maybe didn't make it clearly in the last section, was that the contract is between the government and G4S. It's direct between the 2 parties. So, you know, we're the landlord at the airport. We follow the processes, but that is set out with the government and G4S. Could it have been done differently if we'd been engaged earlier? Potentially. Do we have any issue with it being a contractor? No, as long as the process works properly. There were a lot of teething problems, but it's certainly something we weren't party to. That whole procurement and the contracting of G4S is not done with us. It's been done with the government straight through to the contractor.
Thank you.
William MacLeod.
I've not been made aware of any difficulties regarding security staff. As Mark says, it was an entitlement by the government with the security firms. I believe the transport contract was also a separate one. Recalling, I think, the tender specification for hotels, other than providing accommodation for rest breaks and meals, I don't think there was any responsibility on the hotel management to be supervising or managing the security service. That was really down to G4S.
Okay, thank you very much. George Adam.
Oh, Chair, sorry.
Sorry, Sandra.
I had another question. I thought maybe Debbie was going to answer that one. Sorry, I had a follow-up question to that. And yep. when I mentioned the newspaper coverage from Melbourne and Australia, and also here in Scotland, basically it was because people felt they were being treated like a prison because you had G4S security guards there, and that was what it was. And I remember Jason Leach mentioned the fact that it shouldn't be like that. So that's the reason I raised that particular one, and obviously mentioned we can't forget that it's the UK government that's forward in this. So the follow-up question I was going to ask, perhaps you maybe have answered that, I don't know, but going apart from the G4S, what training and other safeguards do you think should be in place to ensure the use of contracted staff, i.e. do you have any leeway in making sure they don't have two jobs or whatever it may be, and basically so that it doesn't lead to the outbreaks that we saw in Australia. Basically, that's my follow-up. That's my last question.
Thanks, Sandra. I'll ask Debbie Schluter if she has anything she might want to add to the replies we've heard around this issue from other witnesses. Debbie Schluter.
Yeah, I think what's clear is you do need to have very strict arrangements in terms of the training of staff, as well as having adequate protection for staff, and also being aware of the aerosol dynamic of this virus. I think what we've learned over the past 12 months is we had a huge focus at the start on washing hands and on fomites, basically substances. And we've learned that actually aerosol, that actually the spread through the air in poorly ventilated settings is as important. And in Australia, they've just come out and said from their hotel quarantines, they are seeing that they need to be attentive also to ventilation and the spread of the virus this way. And I guess as a final note is we do need to use testing as well. I think, there's multiple checks you can put in place that we need to be having. And going into the future, I think those multiple checks will have to be, a negative test on arrival. Also adding on top of that, testing perhaps at the airport or after 3 days, then testing at 5 days. But I think the more kind of layers you can put in of protection, in a sense, you can't stop everything. And I think that's one of the lessons. There will be flare-ups you have to deal with. But the more layers you can put in of safeguards, the more robust your system will be.
Thank you very much. George Adam.
Thank you, Convener, and good morning to everyone. I would like to ask, obviously the frontline staff and all the organisations represented here today are the ones that are facing the risk of infection every single day. And I'd like to ask, are all staff working in airports, providing transport and working in hotels and providing security support, are they adequately protected for the infection? And if they are, what differences have you made as an organisation or an industry to ensure that is put in place?
Mark Johnston.
Yeah, well, the safety of our staff has been paramount throughout the pandemic. As you probably know, the airports have remained open. So it's a key worker situation. Very quickly, we had to establish safe systems of working, risk assessments in each of the areas, and that will vary from a maximum amount of people allowed in a restroom at any one time, to social distancing, to use of PPE whenever required. So we've been into this for nearly a year now. In all honesty, the airports have been relatively empty for most parts. When we thought we were going to start to get somewhat of a summer getaway last summer, we had to be more careful in our planning to plan for more passengers in the terminal. But I'm pleased to say we've had very little, if any, flare-ups of any instances of someone passing it on to someone else at work. So we're happy with the provisions we've got in place just now, but we won't be complacent because we need to look after our staff.
Willie McLeod.
Yeah, I think, again, reverting to an earlier response, I think the businesses involved in providing this service are, if at all, they're actually putting in place procedures that would be more robust than normal. But when hotels were operating, they all have to abide by, in our case, Scottish government guidance, and many of the companies have their own operating processes to deal with COVID. And although we as an organisation had produced, I think it ran to several hundred pages of guidelines for different types of business in different hospitality and accommodation settings, I would say most and probably all businesses were observing these protocols very rigorously. And I think in the quarantine hotel there will certainly be PPE available to staff. There will be stringent hygiene arrangements in the public areas and the staff areas of the property. Minimal, if any, hotel staff and the quarantining guests, and one of the lessons learned from Australia, and reverting to what Devi Sridhar was saying about aerosol transmission, I think there was one incidence of transmission in Australia where people in rooms with the doors directly opposite each other on the corridor, they opened their doors at the same time when meals were served. Meals are left outside guests to take into the room. There was a transmission of infection from one room to the other because the doors had been opened at the same time. I think one of the lessons we've learned is that delivery of meals would be staggered to minimise the risk of people, different parties, quarantining, actually coming in touch with each other or occasioning a transmission. But generally speaking, I would say that the safety of staff is paramount, and there must also be some cooperation between the hotel staff and the security staff to make sure that they're all operating to the same protocols.
Devi Schluter. Can I call Devi Schluter? Yep.
The safety of staff and those working in quarantine facilities. So Australia has started its rollout of vaccination, and it has started in those places because that's where they're most likely to see cases. In the UK, we obviously have a different problem. We've had substantial community transmission. Therefore, it made sense to start the vaccination program in the community at those most at risk of death. But looking forward, if we do have this ambition, which I think is feasible, to vaccinate all adults, meaning all those who would be working in these facilities by mid-July, possibly those in the risk groups much sooner than that, we are heading into a better and better position in terms of the safety of people working in those settings. It was considered by the JCVI, which determines the priorities. You might have heard this around teachers, around police, and the JCVI decided not to prioritize those groups at this moment. And from my reading of the advice they gave, it was actually a practical issue. With the way the NHS is centered, they can move faster with H. It can just move quicker, and we've seen how fast it's moving. Or if they have to move by occupation, it would slow the program down. And so they said for actually covering the most amount of people the fastest, we could actually get into the 40-year-olds, the 30-year-olds faster if we went this route than if we went the other route. But I think for those planning kind of safety in the next few months, the vaccine is going to really help in that. And it's not life years away. It's actually just months away as we head into the summer months. And if traffic does pick up as we head into the autumn months, that will help protect those who are actually on the front line.
George Adam.
Thank you, Convener. One of the other questions I'd like to ask is obviously much of your staff are working in probably under more strain and more mental strain than they've done in the past. How is the mental health of your staff actually supported by either the hospitality industry or by yourselves in the airports?
William MacLeod.
Differ from company to company, but all employers have a duty of care for their staff, whether it's for their physical health or their mental well-being. And I think one of the starting points for this will be to train staff as well as possible, to reassure them, but I think also to listen to any concerns that staff have and to address them. And if any member of staff has particular concerns or exhibiting particular problems, then I think it's incumbent on the management of the business to address these.
Mark Johnson.
Yeah, it's a good question because it's something we identified early on as a big problem. Living through a pandemic isn't easy for anyone. So we've always had something called an employee assistance programme in place where anyone can pick up the phone and speak to someone 24 hours a day and get support for mental health or any other life stresses for that matter. But our Chief Executive, Derek Provan, he does a blog every 2 weeks. It's a live cascade to the entire workforce. And he's also introduced someone who's a mental fitness practitioner, as he calls it. And he's been running separate sessions to the whole group to help everyone deal with the pressures at work, the pressures of a pandemic, and that's been extremely well received.
George Adam.
Thank you, Convener. Finally, I'd just like to ask, I've got a constituent who has business interests abroad and uses Glasgow Airport quite often. You'll be glad to hear, Mark. That he has probably said in the past year or so, he's probably spent about equivalent of 2 months in isolation at home when he's come home to do the 2 weeks of isolation. So, in your opinion, are the general public complying with the regulations and guidance? Because I can see that could be quite challenging to someone in that situation that I've just mentioned. And what is the protocol if someone doesn't comply?
Mark Johnson.
It's a good question again, because it's information we're not privy to. We've asked that question a number of times to say how effective is the isolation, because isolation only works if people follow the process, as you say. We've been campaigning now for the best part of a year for testing as outlined previously, testing on arrival, test to release. So we believe through the work, we actually commissioned some work with a health practitioner in Edinburgh Airport, and we worked with the government for what was nearly 5 months on a proposal that was to be taken to ministers. Unfortunately, that was dropped kind of at the last minute, and we never actually got to find out what was proposed to ministers. But we genuinely believe that testing is the safe way out of this, because we can't have these restrictions in for any long length of time from now.
William MacLeod.
I think referring probably to my earlier answer, as a trade body, we would recommend good management practice for staff for their health. And I think Mark has outlined the sort of arrangements that a good employer would put in place. And I think that's the kind of behaviour we would encourage individual operators to adopt.
Absolutely. I guess what I was looking to discover was whether you had the same experience as Mark Johnson of not being able to establish how effective the system is in actually public compliance in line with George Adams' question. William MacLeod.
Back I've had from the businesses involved are concerned, the compliance seems to be fairly universal on the part of the people who are required to quarantine. The actual management of the compliance is down to the security staff, and that would very much fall within the terms of the security contract. I think the individual hotel and the individual hotel management would be concerned if there was any failure to observe the conditions of quarantine, and the first referral really would be to the security staff, and then any fallback that may be contained within the contract.
Okay, thank you very much. And I now call David Stewart.
Thank you, Convener, and good morning to all our witnesses. I'm very keen to hear a bit more about international experience. My main interest is about COVID passports, which was referred to earlier. I've raised this with the First Minister and at the COVID Committee and with the Health Secretary. But what I have observed is that the EU is marching ahead with this, with their COVID passport plans. Airlines like Qantas are looking at this issue. My own view is that I can only see the world's economy, particularly in tourism, being managed and operating anything like normal as if we have an internationally recognised passport, particularly one done through the World Health Organization. Again, just to give you my interest in this would be of a digital nature. It may also give test results, and it may also look at using one of the apps like the Protect Scotland app we currently have. And finally, before I ask our witnesses for their comments, I also am very conscious of data protection and individual liberty. This is obviously a difficult balance to get, but the main focus would be on access to travel and not to day-to-day services. I understand there is more social and individual liberty issues around that. So I would be really keen to hear the views of witnesses on these proposals.
Debbie Schluter.
It's a great question. I think you're absolutely right that this is where the world is going, though it does bring in real inequality issues. And I'll mention, I didn't know you were interested in this, but our team has just finished a report where we review international experience on this, and I'd be happy to share that with you after this to have a read through. I think we are heading that way. We're already seeing, as you talked about in the EU, this being discussed to remove quarantine removals and free movement within the EU. We also have seen something called the Common Pass app. I don't know if you come across this, which is a partnership between JetBlue, Lufthansa, Swiss Airlines, United, Virgin Atlantic, which basically tries to be an app where you can upload your medical data, your COVID test result, your proof of vaccination by a hospital, and then you get kind of a pass in the form of a QR code that allows you to fly. So already airlines are heading in this way because they know this is the way we can get back travel. The reason the World Health Organization has not moved in this way is because we do not yet know conclusively that vaccination status reduces your risk of transmitting to others. We know for sure, I would say, based on the data over the past few months, that it reduces chance of hospitalization for Pfizer and AstraZeneca. We know it reduces the chance of death. And we're seeing signs, so there's a study out of Cambridge with health workers, a study out of Israel with social care workers, that it seems to reduce people becoming infectious, which is really brilliant because that's the missing piece in a way. And I think once that's conclusive, they will move towards that. The other reason I think there'll be kind of a pushback against this is because we're seeing very unequal vaccination access across the world. So while the UK and Scotland will be done by mid-July, I mean, 130 countries have no vaccines and little chance of having access to any kind of these. And so it leads to questions over, will this create a two-tiered system where those which are in richer countries will get this? You're already seeing as well, Lufthansa is offering a service that you can fly to Russia, get vaccinated and fly home. For those who want to kind of get ahead of the queue. In the States, we're seeing this as well. So I think this is the pushback around the ethical issues, but it's coming. And the next stage, as you mentioned, is even domestically, that we're looking at, Spain and Greece are looking that even to access clubs, to access bars, Israel's introduced this green pass system. And this is also to encourage young people to get vaccinated, because many people in their 30s think, why should I get vaccinated? But if they are playing an important role in spreading it, and Israel has shown that actually it's 20s and 30-year-olds, that's when you stop the spreading. Because we know it's 20 to 40 who spread it. The people who suffer are over 60, and then those who have health issues. That's kind of the problem of COVID. Who it affects isn't who spreads it. Then you can really then start creating an incentive for people to say, if you want to go to the concert, if you want to be able to be active in the places where spreading occurs, then you have to protect and make sure you're not infecting others. So it's heading this way, and I think you're right. Scotland needs to be ahead of this and preparing for it and thinking, actually, if we're going to do it, how do we do it properly?
Mark Johnson.
Helpful.
Yeah, I think, just as was discussed there, it seemed to have a lot of momentum and then it went a bit quiet and it's gained a lot of momentum again. As an industry, we'll just support whatever the simplest means of a safe return to flying is, and it looks like the vaccine passport is certainly a good option for that. Quarantine in the short to medium term, the longer we have quarantine, the less people are going to fly. We want a safe return to flying. There's a lot of complications with the vaccine passport, but I think they need to be ironed out because it's certainly the thing that looks like the front runner to bring us to some kind of normality, that with the addition of testing when required.
David Stewart.
Thank the witnesses for their very helpful contributions on that. My final question really focuses on the Australian experience, which has been touched on, I think, in earlier questions. But I would just, for the record, be interested to hear the witnesses' views of the Australian experience of quarantine hotels, and specifically the case for a different quarantine period. So, as you will know, in Australia it's 14 days, and here it's 10 days. So I'd be very grateful for the views of our witnesses.
Debbie Schluter.
Yeah, so I guess this has been much debated across countries. You have places like France, which have dropped down to 7 to 10 days, and you have Vietnam, which is at 21 days because they're worried that some of the new variants have longer incubation periods. And as we've seen, the longer the quarantine period, the harder it is to actually have international mobility or any kind of aviation support because it's such a long period. I think the thing that we're realizing is it's very difficult in as connected a place as Europe to be as isolated as Australia or New Zealand, to completely seal yourself off. And so I think the 10, I'm not justifying which system's better, kind of explaining, I think the rationale here is 10 days catches the bulk of cases. So you can reduce to 10 days with testing and be pretty sure you'll catch 80 to 90% of cases. You won't catch 100%, but that along with a test and trace system means you can keep the virus at basically elimination levels, or low endemic, you might call it. So flare-ups, clusters. The analogy I've used, not because they're similar viruses, but because of how we manage it, is something like measles. which is not that we never see measles. We see measles outbreaks, but they're handled quickly, and our systems can respond to it because we do have pretty good public health response systems for small kind of level infections. So I think the whole system of kind of 10 days was saying we can shorten this, have higher compliance, and use testing to try to get around some of the issues in terms of taking out the risk of releasing people from that earlier than 14 days. There is an issue with the new variants. One of the things looking ahead, I'm slightly worried about is if a new variant emerges that has a longer incubation period, it has a selective advantage. It can evade our current systems of response, which means it will spread more. And so one of the things we have to constantly as scientists be evaluating is, has the incubation period changed, and does our advice then need to change alongside that? Right now, this seems suitable, but that could change in a month or two as more and more variants emerge right now. And we're at a crucial moment with variants because of the selection pressures, which means those variants that are more transmissible, as we've seen with B117, which we've seen take off in Scotland from a few cases to now being, the dominant strain, are starting to kind of emerge. And that's going to be the challenge, is any advice we give will shift according to kind of the new variants and the scientific evidence on actually how long the incubation period is.
Thank you very much. And I call David Tollens.
Thank you, Convener, and good morning to witnesses. The UK Scientific Advisory Group for Emergencies concluded that mandatory quarantine of all visitors upon arrival in designated facilities, irrespective of testing history, can get close to fully prevent the importation of cases of new variants. And this is important because of what was announced yesterday with the 3 cases of the Brazilian virus in Aberdeen. Can I ask, what is the scientific evidence for the current international travel restrictions in England, and particularly of the use of red lists of acute risk countries?
Debbie Schluter.
Yeah, so, I don't think it makes much sense to be focused on red list countries. And the reason for that is twofold. The first is that the way people connect and move is such that they try to evade being on a red list country. So to give you an example, if you fly from Brazil, which is a red list country because of the variant they have, to Madrid, and then Madrid to London, you'll be on a flight with many other people who are just flying Madrid to London. You get to Heathrow, and if you're flying from Madrid to London only, you go home. If you're flying from Brazil, Madrid, London, you go into managed quarantine. But you've just been on a flight together for 2 hours and sat together. So do you see what I mean? It doesn't make much sense because your risk is pooled. And this is why, early on, even when people focus President Trump, former President Trump, I should say, was talking about, China bans. He was slightly on something that, yes, you can restrict travel, but actually a lot of the importation did not come from China and Scotland. It was not Wuhan, it was Italy and Spain and France. Do you see what I mean? So it's very hard to predict exactly where it's going to come from given how people move. And that comes to the second point, which is that we have sequencing in places like Britain and Denmark, and now increasingly in the United States. We don't have sequencing in most countries of the world. So we only see on the red list where they've detected it. So we've detected it in Brazil, we've detected it in South Africa. There could be strains circulating in Malawi. There could be strains circulating in Lithuania. We don't know. And so the issue becomes that you're kind of flying blind because you're reacting. By the time you've reacted, probably it's already been seeded here and is spreading. So I think the Scottish approach is more wise because you either want to do it for anyone coming in or you want to do it for no one coming in. If you just do it halfway, you're taking the hit because less people will fly because it's disruptive without the associated benefit of actually catching new variants as they emerge and come in. And I think the misunderstanding people say is, oh, we can't shut down the world forever. And I'm saying nobody's saying shutting down aviation forever. We're actually saying, let's build up the system while we're having our vaccinations going to actually do this safely. And then people will fly and we'll have a more robust recovery to airports and to airlines when actually people fly with confidence because they know they won't infect others, they won't be infected, and there's appropriate testing in place, vaccination procedures, as well as, increasingly as well, quarantines until we can get around that.
Mark Johnson.
Yeah, just to add a bit of context to the learnings in terms of, obviously, the borders as a government policy, they will control that. Our understanding of what's happened in Australia and New Zealand is the governments have taken a move to effectively close the borders with the managed quarantine, but they've also put money into the sector to the tune of hundreds and hundreds of millions of dollars. So the point I would make is if you are putting in managed quarantine and things like that, which effectively shut down aviation, you can't do that without looking at the consequences and understanding that we've had nearly a year now without any flights. We're 98% down on passenger numbers of where we were this time last year. Unfortunately, we've lost more than a third of our workforce, so there's thousands of jobs that have gone. We're very grateful to the government for confirming the business rates relief, but sadly that amounts to less than 8% of our fixed costs while we remain open to keep the country moving. So we would have burned that money by the end of week 4 of the year. So I'd just like to make the point that in times when the restrictions are as severe as they are, it's extremely important that we recognise the airports can't keep operating with such a high fixed cost, and sector-specific support is required with those kind of policies in place.
Thank you very much. I call Donald Cameron.
Thank you, Convener. I have a general question about the how effective has the Four Nations approach been on international travel, and what have been some of the practical challenges arising? And I ask that question in the context not just of the differences that the Scottish approach has with England, but also the differences that it has with Wales and Northern Ireland. I wonder if our witnesses can answer that, please.
Debbie Schluter.
Yeah, so it's been challenging, I think, because there hasn't been full alignment between at least what number 10 is saying in terms of UK-wide policies with the red list, and also what we've seen, Scottish government say, which is actually trying to stop all variants coming in from anywhere. And I think it comes down to a difference in strategy and what they're trying to achieve with the virus, which remains to be seen. I don't think anyone knows in the next 3 years how this virus will look, if I'm completely honest. I think we have different theories of how we think it could evolve, including one that it could become like a common cold coronavirus and circulate. But unfortunately, when this virus has mutated, as we've seen with we might call the Kent variant or B117, it's mutated to a more transmissible form, so more like a common cold, but at the same time become more severe and causing more hospitalizations. So it hasn't gone the way we want it to go, which just shows this virus seems to kind of go in a different direction. So I think what we're seeing now is a little bit of a need to align on where we want the vision to be. And we're seeing, and this is my strong view, as I've said for over a year now, is that we need to drive the numbers really low, because the more freedom and the more economic recovery you'll have, the lower the virus numbers. And this is what you can see in the countries that have performed better. McKinsey, other analysis have said the same thing from the economic side, where I think there is a feeling in England that actually we can live with this like a seasonal flu, and therefore we accept a certain number of cases, which means we can be more lax around our international policies, because we accept, for example, SAGE modeling is at 30,000 deaths in the coming months, because that's just, we accept 9,000 a year for flu, so why don't we accept 30,000? And I've heard the same debates in the States. Do we accept a certain number of deaths, and that's just how it is? I think that's quite a difficult proposition right now, because this virus is so infectious that you can't just say we accept 1,000 deaths a day or 500 deaths a day. It doesn't work like that. It's either going up or it's going down. That's the importance of R. And so I think this is kind of why we're seeing variations. It's like, what are you trying to actually do with this virus? And until we get some consensus on where this is going, it's going to be very difficult to get alignment. But I think now that we've seen the Brazilian variant come in, and we've seen some of the difficulties in managing it, and I know in England, they're still trying to find one of the people who tested positive, and they're seeing the difficulty not having appropriate tracking in place for that. They might tighten the system because you don't want to undermine a whole vaccine program because you import a variant. I mean, Israel stopped all flights in and out of the country until they vaccinated their population. Norway, similar policy. Canada now is very similar to where we've gone in Scotland, where all international arrivals come into certain airports and they go into managed quarantine. And then they can go home to finish it after they've had 2 negative tests, but they must go to hotels. So I think more and more you are seeing countries go that way, because the vaccine is wonderful until we get a variant that somehow makes it not as effective. And then all of a sudden it puts us back a few steps and nobody wants to go backwards.
Donald Cameron.
Thank you for that answer. And I think you covered in the answer some of the issues in my next question, which was to ask about the potential for undermining any country's ability to suppress the virus. I wondered, is there any evidence so far of people bypassing the Scottish system by flying via England or Wales or Northern Ireland, where there's a slightly less strict regime. For instance, travelling to say Manchester or Newcastle and then up to Scotland. Is there any evidence of that actually happening?
Mark Johnson.
Yeah, well, that's the challenge we have with the two different policies that are in place and the loophole that effectively exists. So the Scottish policy is a blanket, no international travellers come into the country without hotel quarantine. What happens in practice, though, is because there's a red list situation for the UK government, it's possible to fly in and then travel back up to Scotland, and then you isolate in your house instead of in a hotel. And that's one of the challenges we've got as an industry, that there's it's quite frustrating and confusing, the discussions around the four nations approach. That creates a big challenge for us in terms of how we administer it, but also at the moment, the UK government have set out a roadmap for coming out of the restrictions, albeit there's heavy caveats on the dates where those things might occur, but at least there is a roadmap with prescriptive triggers, if you like, for each stage of coming out of it. And what we're already hearing is that the bookings for flights from England, postcodes from Scotland, there's lots of people booking flights down there, and anecdotally we hear from the airlines the potential that they will move their capacity down south because there's no effectively light at the end of the tunnel or roadmap in Scotland. So it gives us challenges. We don't manage the health side of things as an airport, but what we do see is the commercial side of things as an airport, and these discrepancies and differences are really challenging for us.
And Mark Johnson, have you noticed from your own experience in the airports any impact on internal connections from elsewhere in the common travel area?
Well, at the moment we're really just, I can't emphasise enough, we are only open for critical flights. It's lifeline flights to Highlands and Islands. We have connectivity to London, to Belfast and to Dublin. For Aberdeen there's some connectivity for oil, but essentially we're having passengers in the low hundreds when we'd normally have 40 or 50,000 across the group. So there really isn't much activity. The airlines have scaled everything back and they plan 6 months in advance. So at the moment they're looking and they're saying, we just don't know what to do. We accept that things might change and can move, but at the moment there is no light in terms of our industry of knowing from a Scottish perspective when we can get back up and running.
Thank you very much. Got a couple of supplementaries. Sandra White, followed by Emma Harper. Sandra White.
Thank you very much, Convener. I was interested in Mark Johnson's reply there in regards to the different guidance from different nations. But what I want to put to the witnesses is, this is a four-nation approach. Surely it would be prudent for each nation to be able to say, this is their guidance, this is the way they want to do it, instead of having a kind of bun fight in regards to Westminster says this, Scotland says that, Wales says something else, and Ireland says something else, because this is really about stopping this virus from basically spreading. So I would just like to ask, wouldn't it be prudent that each nation look after, obviously, the people that they're representing, the governments, and therefore, in the situation we now have the Brazilian, virus now here in Scotland, and there is evidence that people are bypassing, and Debbie had already mentioned that previously as well, going from one area to Madrid, etc., London, and then they're moving on up to Scotland by car, by train, or going in a plane, which happened with the Brazilian virus part of it. They're in a plane with other passengers on that plane as well. So I just ask, wouldn't it be the proper way to go about it, that each nation decides what's best for them?
Thank you very much. I'll take Emma Harper's question as well, and then ask both witnesses to respond to both questions. Emma Harper.
Thanks, Convener. Thanks for bringing me in. It's a question about vaccines and variants, and I take on board what Mark Johnston is saying about how completely affected the airline business is. And I'm wondering, and maybe it's a question for Professor Schluter, is about managing quarantine or the need to manage isolation is going to have to continue for a while. And my concern is that we've got these new variants. So we saw how the Kent variant entered Dumfries and Galloway, and we went from a tier 1 to a tier 4 almost overnight, just before Christmas. And it was just massive. And now we've got people asking for a Pfizer vaccine or an AstraZeneca or a Moderna. People are choosing their vaccines based on whatever information they're getting. And I say that as a person who's a vaccinator in NHS Dumfries and Galloway myself. So I'm curious about what do we know about vaccines and effectiveness on new variants, because I'm imagining that we really do need to be careful on how we look for any virus coming into the country and manage it so that we can get the levels as low as possible. But my concern is that the new variants might not be touched with the current vaccines that we have.
Thank you very much. My mistake, these questions are slightly different, but nonetheless, if both witnesses can deal with them both, I'd be very grateful. Sandra White's question on the regimes and Emma Harper's question on vaccines. Take Debbie Schluter and then Mark Johnson. Debbie Schluter.
Yeah, so on the first one, I mean, I think all 4 nations, having observed this as an external person for the past year, need to work together. And the reason is for twofold. The first is we have a shared border. And as long as we have a lot of traffic across that border, I think its efforts are more fruitful trying to reach a collaboration and a coordination agreement across that border of how we actually work across all 4 nations than it is trying to police it, because we really shouldn't be policing people's movements any more than we need to be. So I think the second thing is that we did know from the start the 2 areas of society where we would be hit the hardest would be travel tourism, because of the mobility of people. And this is every country. And a lot of the passenger traffic coming down is not only because of the restrictions, it's because of the virus. I mean, the pandemic has affected how people behave. So even if the airports were completely open, which they were actually for a lot of the first lockdown, I think anyways, the passenger numbers were down because people shifted their behavior because they didn't want to travel when there was a virus circulating. And the second is the hospitality sector, bars, clubs, nighttime, live music. We always knew this would be difficult. And so you need financial support to these sectors. We need to support aviation so we're not having that kind of job loss, and support hospitality. And I think in that sense, as we move out of kind of lockdown measures, we need to release and get people back to work where we know it's safer. And we need to concentrate our financial support and government support on those sectors which we know will struggle because of the nature of the pandemic, which is aviation and associated travel and tourism, as well as hospitality. And that, unfortunately, is beyond, I guess, the full control of any one nation. That's kind of a 4-nation thing that needs to come from down south and from London. The second question on variants and vaccines. So right now, we've been lucky that this B117 variant that is taken off here is more transmissible, but it doesn't seem to reinfect people who have had COVID, and our vaccines are still pretty good against it, AstraZeneca and Pfizer being the 2 that we're using here. As new variants emerge, we need more mutations, and this is why the P1 one was worrying, because it has 3 different mutations in it. The question is, will people get reinfected who have already had COVID? And so is it so different that our immune system can't recognize it and our antibodies and T-cell response can't protect against this new version of it? And the worrying thing out of South Africa and Brazil is, in South Africa, they have done tests with the new variant and found that actually it is reinfecting people who have had COVID before, which means it's not like you can work your way up and you have some kind of immunity. It means you get waves of it because people might get the newer version. And in Brazil, they found even that people were having 2 different versions of COVID at the same time because they were so different. So this is the worry. Luckily, the vaccines still seem to be pretty good against these variants. Johnson & Johnson is working even against the South African strain, and they're rolling that out in the States. I know we'll get stock of that later on this year. So I guess the 2 kind of final things to say is that right now we're a little bit in a scientific uncertain plane. We don't know what new variant will emerge. It depends now, with more and more replication of the virus, more mutations occur, and some have a selective advantage. They continue, some don't, they burn out. And unfortunately, those that have a selective advantage are those that can reinfect people who've already had COVID, because those that can't die out, those that can will spread. And so we're a little bit gambling with how much do we want to permit international mobility and travel, in the hope, like the red list approach, that we can catch some of it and something bad won't really happen, and the chance of could something really difficult emerge in a variant. And it's uncertain. I don't think any scientist can say for sure, but it's how watertight do you want to be in that? And that's, I guess, your approach to uncertainty and how much risk you want to take at this point in the pandemic. On the good news, I think the mRNA vaccines, this is Pfizer and Moderna, which use this new technology, can quickly change it. So Moderna has already created a South African booster. So in the States, you can get that when you get your first one. We haven't yet gotten Moderna, and we'll probably get that in May or so. So they can change it quickly, and that's really positive. The time lag will be once we have it to actually getting it into enough people's arms so that we don't reduce the spread and reduce any associated hospitalizations. So in a way, we don't want to be in our current position of having a vaccine, but having to wait to roll it out to all the groups and needing in place restrictions, because that'll be the lag. They can redevelop it, I think, within weeks. The challenge will be in manufacturing it and deploying it. And as a rich country, the UK and Scotland, I mean, we're all in a really privileged position to have that, be in that position. But it's the time issue. And all of a sudden, if you're into buying time and slowing the spread, you need to put in brakes. You're going to have to put in restrictions. And nobody wants to be back on restrictions once we lift these in the next few months.
Thank you very much. And finally, Mark Johnson.
I'll pass on the technical question about the effectiveness of vaccines. I think that's Devi's done a great answer there. In terms of the Four Nations approach, all I would say is we want it simple and consistent. I don't know how we achieve that, but from a customer point of view and from our point of view as an industry and a way of getting out of this, simplicity and consistency against the backdrop of really difficult decisions that need to be happening just now, I think are really important. So we would support that, absolutely.
Thank you very much. And can I thank all our witnesses this morning for what's been a very useful evidence session. And it's exposed, I think, some of the questions that we will want to follow up with others in order to establish some of the detail that is not entirely clear, but it's also been very informative in terms of both your perspectives and your practical experience on the ground. So thank you very much, and we look forward to discussing the same issues with the Cabinet Secretary next week. Thank you. We now move on to the second item on our agenda, which is an evidence session on Audit Scotland's report, NHS in Scotland 2020. And I welcome to the committee the Auditor General, Stephen Boyle, who is accompanied by Lee Johnson, Senior Manager in Performance Audit and Best Value, and Eva Thomas-Tudo, Senior Auditor in the same section of Audit Scotland. Thank you all for joining us today, and can we start with a short statement from the Auditor General, Stephen Boyle.
Thank you, Convener. Good morning, everybody. Delighted to be with you this morning, and many thanks for inviting us to speak to the committee. Our report on the NHS in Scotland focuses on the Scottish Government and the NHS COVID-19. We also choose to update on the financial and operational performance of the NHS during 2019. The challenges that the NHS has faced as a result of COVID-19 have been unprecedented. NHS staff have worked tirelessly in difficult circumstances to deal with the demands of the pandemic while maintaining access to essential services, reflecting their extraordinary commitment. The Scottish Government had difficult decisions to make about how to prevent the NHS from becoming overwhelmed. During the first wave, non-urgent treatment and national screening programmes were paused. There are longer-term risks associated with some of these decisions, but the Government needed to create additional capacity for COVID patients. There is now a significant backlog of patients waiting to be seen, but the pandemic is ongoing. Continuing to respond to the pandemic is resource intensive, taking priority over resuming the full range of NHS. The way the NHS delivers its work has changed drastically, with many new approaches established. Several large-scale initiatives such as COVID-19 Community and the widespread use of short appointments, together with the procurement and distribution of huge amounts of PPE and the creation of the NHS Louisa Jordan, were implemented at pace, by partnership to an extent not seen before. Going forward, stable collaborative leadership will be required to remobilise and renew the NHS and learning scene. COVID-19 has not affected everybody equally. Those from our most deprived communities, certain ethnic minority backgrounds, are more likely to have been hospitalised or died as a result of contracting COVID-19. Scotland's long-standing health inequalities remain to be addressed. The Scottish Government could have been better prepared. Planning for a pandemic not been sufficiently prioritised. Improvements identified through pandemic preparedness exercises were not all fully implemented. COVID-19 is expected to cost an extra £1.7 billion of expenditure across health and social care during 2020-21. NHS boards are being fully funded this financial year, but there is uncertainty about the longer-term financial position. Convener, myself and my colleagues are delighted to be with you this morning, and we'll do our best to answer yours and the committee's questions.
Thank you very much. Can you say a little more? You talked about the longer-term risks which have resulted from decisions taken early on in the pandemic, and I think you mentioned particularly people waiting for operations or for screening or screening opportunities missed. I wonder if it's been possible for you to quantify these risks. Clearly, these risks exist. We know about delayed operations and so on. Is it possible to quantify what the volume of cases which might be affected might be and the level of risk? Stephen Boyle.
Thanks. I'll start, and I'll invite Eva to come in. She's done a lot of the data analysis. The general point we make here is about the need for transparency around the extent to which services have been delayed, and that patients are clear on the anticipated wait time that they might have for future access to services. The report references the government's intention to pause what had been a very significant programme of waiting times improvement, and to pause that in light of the pandemic, move to the category prioritisation. We emphasise that needs to be done clearly so that patients understand what that means for their access to services in the future. There is a very significant implication for the pandemic. What our report doesn't do, though, is to assess the extent of health implications for individual patients as a result of the pausing, but then the emphasis, the need to have that clarity about what it means for future service delivery, to allow the NHS, as it's going through very significant mobilisation and planning, that it does that in an open and transparent way. But I'll ask Eva maybe to say a little bit more about what the data has shown us in terms of if there's anything more to add on that.
Eva Thomas-Tudor.
Thank you. Yeah, so Exhibit 5 gives a good indication of the impact of the pandemic on demand and activity for NHS services. So that shows that the number of people waiting for treatment and waiting much longer for treatment has increased since the start of the pandemic. Another indication as well is that referrals to hospital care has decreased, which comes with risks associated with that. So the likelihood is that there aren't fewer people needing hospital care since the start of the pandemic. So the reduction in referrals could indicate that people that would otherwise have been referred for hospital care have not been since the start of the pandemic. So we'd be looking to see what the longer term health outcomes, the impact on health outcomes would be because of that. So just to give an indication of scale, the referrals from all sources, so including from GPs, was about 450,000 for each quarter in 2019. That reduced to 188,000 between April and June 2020. So it's less than half number of people being referred.
So really quite substantial numbers involved. Yeah, thank you. I wonder, one of the other things that the report covers is how far the Scottish Government was able to project the needs arising directly from the pandemic, and so questions, for example, around bed capacity in hospitals, intensive care capacity, and testing capacity. I wonder if there's a general conclusion that you have drawn around the effectiveness of those predictions, and whether more accurate predictions might have had different results. Stephen Boyle.
Thank you, Convener. Again, I'll turn to Eva. Maybe she wants to say a little bit more in a moment around some of the capacity within hospitals. I'll maybe start by saying a little bit more about the testing capacity and what our work has found. We report in detail some of the numbers around testing capacity, and effectively that by December of 2020, that the government had an effective test and protect system in place, that it had met in accordance with the criteria set by SAGE, that its capacity was such that it was able to test and trace up to the relative levels of percentages that allowed it to meet the criteria. In terms of overall bed capacity, we maybe haven't gone into as much detail, and I think what we looked in this report is to form the initial assessments during the course of the pandemic, with the intention very clearly in our next report during 2021 to update much more on the impact of the pandemic and what it begins to look like in terms of health outcomes, the extent to which public money has been well spent. So we'll report that further in 2021, but I'll maybe ask Eva again if there's anything more that she wishes to say on some of that analysis.
Eva Thomas-Tudor.
Thanks, Auditor General. Yeah, just to point out really that at the start of the pandemic, intensive care capacity was increased, and that's kind of one of the main reasons that a lot of that non-urgent care was paused, to increase capacity for COVID-19 patients. And that meant that the NHS wasn't overwhelmed during the pandemic. So intensive care capacity was increased from 173 beds to 585. The peak in the first wave of COVID-19 patients and non-COVID-19 patients in intensive care was 250. So that shows that if they hadn't increased the intensive care capacity, that the NHS would have been overwhelmed. So I think that is showing that was effective.
I wonder, just following up on that, perhaps with the Auditor General in the first instance, if we've seen, I suppose you could say, 2 waves of COVID cases in hospital, and issues have arisen as to how quickly ordinary services, if you like, elective operations, for example, have been restored as the COVID numbers have gone down. Did you take a view on that in the first wave, and have you a recommendation for that in relation to the current position, or the position we're now hopefully in, where cases are again going down in hospital? Auditor General.
Thank you, Convener. I think I lost the sound a little bit in your question, but I think effectively looking to the detail of our work in terms of the implications around some of the clinical choices that we're making. If maybe just check that with you.
And essentially, we heard how routine work was set aside because of COVID at the outset. The next question is, when does the NHS return to that routine work, because the worst peaks of COVID are behind us? Did you take a view on that in 2020, and do you have a view of that going forward for 2021?
Yes, so you're right, Convener. It certainly forms a key part of our work during 2021. I think in this report, so we report on, I think, particularly a couple of kind of key points. One is the analysis of A&E attendance. Excuse me. We saw through the early stages of the pandemic that attendance dropped significantly, and the risks around that for patients of all cases, particularly for acute instances of heart disease, stroke, and other illnesses that may have not been detected that an A&E presentation might have. We track that during the course of the year. We report that the NHS campaign around the NHS is open, so growth in A&E attendances, but not yet back to the levels that they had been. So there is more, and then it dropped away again in the autumn during the second wave, and still that kind of nervousness around the public for what might mean engaging medical services. So an important role for the NHS is to still emphasise the availability of its services. We also looked at the instances of the kind of early stages of the pandemic and report about the pausing of the screening programmes and some of the clinical risks that may have been involved in those decisions, by necessity, as Eva has mentioned, to ensure that the NHS wasn't overwhelmed. But undoubtedly what we're not seeing, and what we'll continue to track through our work, is what that means for clinical outcomes as we move forward, and pick that up in our report again later this year.
Thank you very much. I now call David Tollens.
Thank you, Convener, and good morning to your witnesses. Auditor General, have you seen any recorded reports for future learning that describes and explains rapid responses to address the threat of the pandemic?
Stephen Barth.
So, in terms of future learning, I think that's a key theme, Mr. Torrance. I think we've undoubtedly seen innovation during the course of this pandemic. I think particularly the scale of virtual consultations, and we make a recommendation for that as the NHS re-mobilises, that it takes a view about what that means and where that's placed in the future delivery of health services in Scotland. We also draw upon the presence of the community assessment hubs, the rapid introduction of those as to where that fits in the future model of what that means for NHS services. As the committee will know, and we've seen your own reports on this, that Audit Scotland has for many years been calling for a review and the sustainability of what health and care services look like in Scotland. And of course now, just in the recent few weeks, the independent report on the future of adult social care. So there is much material available about what will influence, no doubt, about the remobilisation and then the future of health and care services. So we're mindful of all of this activity and placing such emphasis and closely monitoring what that means for the future plan and remobilisation of health and care services across the country.
David Torrance.
Thank you, Convener. Auditor General, you partially answered my next question, but what elements of the new structure should be retained?
Stephen Barr.
So I'm mindful, Mr. Torrance, about kind of my responsibilities, and one is not to comment on policy matters. Ultimately, it will be a decision for government to determine the future establishment and structures of health and care services. And there, as I say, there is much comment and opportunity. In Audit Scotland's work, we've been commenting about, particularly in recent years, about the pace of integration of health and care services, the sustainability of the current model, which was designed, as we know, for an era about a much more significant focus on the presence of large hospitals and people receiving health services in large acute settings. And whereas in recent times, increasing focus on the provision of care in more homely settings, closer to people's homes, and more preventative medicine. So all of these will be factors, no doubt, that will be taken into consideration to determine what that looks like.
David Tollens.
And my final question, Convener, are there any risks or unintended consequences associated with any of the new ways of working, such as the new clinical triage arrangements?
Stephen Boyle.
So we've been clear about this actually, and it was a similar conversation with the Public Audit Committee last week about what some of these innovations might mean. And I think particularly the conversation around the rapid growth in the use of virtual consultations. But at a time, by necessity over the summer and lockdown, that has grown really exponentially up to, I think, the figure we use in our report, of 600,000 virtual consultations. But it might not suit everybody, and I think that's so we're not clear. We're not health professionals, and what we wouldn't know and why we think there's a need for that analysis that goes alongside this rapid change. Are there any unintended consequences of that? Is there anything that would be lost either through people having restricted access to technology that may prevent their ability to access services, or whether a face-to-face consultation provides for both the clinician and the patient to have a better interaction. So all of these things need to be considered as we've moved at such pace to implement changes to the way health and social care services are implemented. And we expect that, Mr. Torrance, to be factored into that thinking and analysis that takes place once the pandemic has eased, and we think about what the future might mean.
Thank you very much. I call Donald Cameron.
Thank you, Convener, and good morning to the panel. I want to turn to the question of the future, and you've touched a little on this already, Auditor General, in terms of the growing backlog, the difficulties that we will have in terms of people who have had treatment delayed or diagnoses missed. What measures do you think should be used to monitor the longer term effects of such delayed or delayed treatment or misdiagnosis?
Stephen Burrow.
Good morning, Mr. Cameron. I'll start and I'll invite my colleague Lee Johnson to come in. Lee has done much of our thinking and analysis on remobilisation. In terms of, there's been much focus in the NHS in recent years on reducing waiting times, and we've seen significant investment gone into reducing waiting times. But with that pause, that decision to pause that and to prioritise on a clinical basis, there's a real important thinking to go alongside the remobilisation. There's clarity around the investment alongside longer term outcomes. In terms of what that means for all of us and all of the metrics that we would want to measure the very significant investment, and I know the committee has got a keen interest, of course, in that we're now around half of the entire Scottish budget is invested in health and care services, and that what we're achieving as a country is very clear alongside that. So as we move forward and implement not just a remobilisation of the NHS, but perhaps thinking about the longer term future and structures of the NHS, that we are clear as a country as to what we want to achieve for the very significant investment that we've made. I'll pause there for a moment, Camille, or maybe invite Lee just to say about what we've seen from some of the material we've looked at about remobilisation.
Lee Johnson.
Officer General. I think we clearly say in our report we make recommendations both for the Scottish Government and NHS boards around the need to, some of the things we've already talked about, around the need to take action to meet the needs of those whose access to healthcare has been reduced as a result of the pandemic, but to also monitor the long-term impact of this on health outcomes. And also, as we've already talked about, to publish data on performance against the clinical prioritisation categories that have been introduced to measure the waiting times and how long people are waiting for treatment. I think it's important to say as well that Public Health Scotland have a key role in this and the work that they're doing around developing different indicators, and particularly I think their focus on addressing the needs of those in our community who have the poorest outcomes. And I do know that the data teams within Public Health Scotland are looking at how we expand the range of indicators that are available to look at some of the outcomes and some of the impacts going forward.
Donald Cameron.
Thank you very much for those answers. In terms of the monitoring, are you aware of any health board that is planning to mitigate in some way the delay to treatment, etc.? And have you been advised of the ways that health boards are, thinking of how to deal with this? Whether that's increasing hospice provision, support for those with a terminal illness, prioritising those who need tests, etc.
Lee Johnson.
Mr. Cameron, we haven't looked at any of that in detail. I think we have to acknowledge that health boards are still dealing with the ongoing demands of the pandemic. We are in the second wave. Obviously, we know that cases are dropping and hospital admissions are dropping now, but at the time of publishing our report, they were right in the middle of the second wave of the pandemic. But it is something that we plan to look at in our next report on the NHS in 2021 in terms of the longer term implications and the new ways of working that are being implemented and how health boards are dealing with the impact of the pandemic on their communities.
Eva Thomas-Tudor.
Thank you. Just to add that the Scottish Government introduced the clinical prioritisation framework that Lee mentioned earlier, and that is kind of intending to manage the current backlog as best as they can at the moment. So people are being treated based on their clinical prioritisation level. So those that are most urgent will be seen first. Those that can safely wait longer to be seen will have to wait much longer. So that's how they're dealing with the limits in capacity at the moment. But as Lee said, we'll have to wait and see what the plan is post-pandemic about how to get on top of the significant number of patients waiting.
And Stephen Burrell.
Thanks, Convener. Actually, I think also through our work we'll be following the implementation of the government's winter preparedness plan that was published in October of last year, which begins to explore options around tackling the backlog, the extent to which the NHS Golden Jubilee Hospital, NHS Louisa Jordan, and even the private sector might be available to support some of the backlog reduction. And as Lee mentions, we'll pick up during our 2021 report.
Donald Cameron.
No, I'm very glad to hear those responses, and I understand obviously that the priority has been over the last couple of months to deal with COVID, but I do feel that looking forward, the backlog and remobilisation is going to be one of the biggest sort of public policy challenges that any government faces. So I'm very pleased to hear that you will be scrutinising that at Audit Scotland. Can I lastly turn to the issue of health inequality? There's been a lot of evidence that the pandemic has widened health inequality, especially amongst deprived and ethnic minority communities. And I suppose my question is, are you aware of any emerging policy to mitigate that widening of inequality, and particularly with relation to the vaccination programme? Have you looked at issues around widening inequality as a result of vaccine hesitancy, for example?
Stephen Boyle.
Yeah, thank you, Mr. Cameron. I'll invite Lee to come in a second. I think we, as others have commented elsewhere, were struck by some of the disparity, the extent to which the COVID-19 pandemic hasn't been equally felt, and how that's borne out by some of the statistics, particularly the very stark difference in implications between our most deprived and least deprived communities in the country, as well as the extent to which it has affected our Black, Asian, minority ethnic communities also disproportionately. So there's some real thinking for government policymakers to do about what that means to take the necessary steps to reduce those inequalities, and the extent to which we would be learned from this pandemic for future pandemics. Of course, we don't know whether this is a once in a century pandemic or whether this will be a series of pandemics that we'll need to take necessary action and incorporate into our lives. By way of the vaccine programme, Mr. Cameron, we've not done terribly much work yet. I think there are opportunities for us to do so as we reflect on the success of what will hopefully be a rollout across the population in time for us to capture that analysis for our overview report in 2021, which will be a key part of our thinking. But I'll just check with Lee if there's anything that she wishes to say more about that.
Lee Johnson.
Thank you, Mr. General. I think the pandemic, as we've already talked about, has shone a light on what I know the committee will know are long-standing issues within Scotland around health inequalities and socio-economic inequality. And the Scottish Government did establish an expert group back in September 2020, particularly to look at the impact of COVID-19 on ethnic minorities. And that group did publish 2 different reports. There was various recommendations in there around improvements around data and the evidence around inequalities and health within those communities. But again, as I said before, I think Public Health Scotland has a huge role to play here. Public Health Scotland was set up or came into being, if you like, right at the start of the pandemic. And have been at the forefront in terms of the response to the pandemic and generating some of the data that we've had around different issues, but really haven't been able to push forward with what they were originally set up to do, which was take that whole system approach to starting to look at health inequalities and the poor outcomes that exist in some of our more vulnerable communities.
Thank you very much. And I call on Emma Harper.
Thank you, Convener. Good morning, everybody. I have a couple of questions on pandemic preparedness and planning for that. The Audit Scotland report states that not all actions from previous pandemic preparedness exercises were fully implemented. And so I know the exercises were Silver Swan, Cygnus and Iris. And the report, I'm looking at paragraphs 43 and 44 and 45 and others, in front of me. The report states that the Scottish Government did not include an influenza pandemic as a standalone risk in its corporate or health registers. And it looks like there, from your report, there was issues recognised that could have been taken forward. So I guess my question for Stephen is, do we know why a lack of preparedness or action in the recommendations from some of the exercises wasn't taken forward?
Stephen Boyle.
Thank you. Good morning. See, you're right. We have drawn a conclusion from our report that there were opportunities in following the exercises for the government and the NHS to be better prepared for a pandemic. Very specifically on your question, we also report that a pandemic preparedness, it was a known risk in terms of the government's thinking, and the implications of a pandemic were also identified as very severe. But what we didn't see in our analysis was evidence that a pandemic featured routinely as a risk that was being actively managed, in spite of what was also the extent of the implications of the pandemic that we've now seen. Other risks featured prominently on the government's risk register at the time, but not the pandemic implications. So I don't have a direct answer to your question as to why that was the case, and we think it's one that, whilst there was visibility of it within government, and there were working groups and exercises that we set out, the extent to which it was escalated to the top of a corporate risk register is not an answer that we have, and it may be the committee may wish to explore that further directly with the government.
Emma Harper.
Okay, thanks very much. Do you think that the planning would have made a difference then if, I suppose in relationship to access to PPE, we saw how quickly that got up and running from initially when care homes, for instance, didn't have access or even appropriate training in the use of PPE. I know that from the standpoint of fit testing for special face masks that are required for aerosolised generating procedures is something that healthcare professionals participate in the training and the testing of those kind of specialist PPE equipment. But have you been able to ascertain what difference there would have been in response to the pandemic in relationship to PPE, for instance?
Stephen Boyle.
So you're right. In terms of paragraph 44 to the report, we highlight really the three themes from the recommendations arising from these three exercises that came then to fruition during the course of the pandemic about the extent to which our care homes were prepared, clarity around roles and responsibilities, and as you mentioned, about the use of and availability of PPE. We've not done the detailed analysis about the correlation between the extent to which PPE was or wasn't available right at the start of the pandemic and what that meant for our health and care workers. Instead, what we have done is draw on the published findings of surveys from the BMA, the Royal College of Nursing, and then right at the start of the pandemic, what some of our health boards were saying about the availability of PPE and the need to purchase that directly. And we've made then drawn a conclusion, therefore, that given the really exponential growth in the use of PPE from under 100,000 in a typical week pre-pandemic times to over 24 million items per week, that the extent of that growth and being unprecedented, there may have been opportunities for us to respond immediately and be better prepared to the pandemic. But not what we haven't done, what we'll continue to look at and monitor through our work and others is the use of and availability of PPE. And the committee will maybe be interested, we'll be publishing further work this year on the extent of the use of contracts for PPE and begin to explore some of the value for money arrangements that Scotland implemented. Last thing to say about it is that Scotland's arrangements are now well in place. So we see through the work of NHS National Services Scotland that there are there is sufficient PPE to support the needs, not just in the NHS, but also within our health and social care settings too. And we comment, last thing to say on this, Ms Harper, is about the use of PPE in social care settings, and that arrangement extends through to the summer of this year also.
Emma Harper.
I'm sure everyone has learned so much about preparedness for pandemics and even future coronavirus type or flu pandemics, and the Audit Scotland report suggests that the pandemic guidance should be updated as a priority. So how soon should that happen, and what should the guidance include? And I'm sure a lot of the guidance can be taken from experiences that we've had over the last year, because I'm sure everybody will agree that we started at a level of needing to, rapidly assimilate and implement issues very, very quickly in order to tackle this pandemic.
Stephen Boyle.
We agree. We think it's something that needs to happen very quickly. We set out some of the chronology of the guidance dating back around 10 years ago, that process had begun to update that. There had been consultation on the guidance for our social care setting in the event of a pandemic, but that hadn't been published. So we agree. We don't think there's any real value in republishing it now, given so much has changed and there's been so much learning that's taken place over the course of the past year. And that needs to be incorporated, that we learn from users of health and social care setting, from our staff in these environments, that it's incorporated into what inevitably will be a fairly iterative document, but not one that I think, probably seen from our extent to which we were prepared and thinking about pandemics previously, that borrows on thinking from 10 years ago, given that there's been so much that's happened over the course of the 10 years, course of the past year rather, but that we do so quickly, that, as you've alluded to, that if there are more pandemics, that we are better prepared and able to respond next time round.
Thank you very much. And I call Sandra White.
Thank you very much, Convener, and good morning, everyone. It is still morning at this particular time. I wanted to ask about the remobilisation of the health service and the staffing also. And I think you've answered some of the questions, but if you have, you can say. And obviously, thank you for the report. Maybe the answer to the question will be the 2021 report. Now, you've highlighted the fact about waiting times and obviously some elective surgery being put back for a while, but you also go on to say that the Scottish Government is committed to rebuilding the NHS differently, and you've obviously given us some examples like providing more care near home and that type of thing, independence between health and social care services. You've mentioned that also. Now, there's a lot of work to be done in that, as your report says, and I just wonder, your opinion on, do you think that the Scottish Government is being too ambitious, basically, in trying to deal with, the backlog at this particular time, and also rebuilding the NHS differently, as you've mentioned in your report?
Stephen Boyle.
There's a huge programme in front of the government, Ms White. There's clearly, in terms of continuing to deal with a pandemic, rollout of a vaccination programme, recovery of a backlog of services, and then the extent of clinical risk that remains within that. Alongside the continuation of the programme of health and social care integration and all of the matters you talked about care, treatment closer to home, preventative services, as opposed to the models of the large acute hospital setting. All of that needs to be tackled, and we do have empathy with the NHS and government to take those kind of decisions. From our own perspective, we'll be continuing to monitor and track that, and about the extent to which the government is taking the steps to implement the ambition that it sets out in its Re-Mobilization, Renewal, Recovery programme, and that will remain a key part of our work. But I do agree, I think it's not something that we say is a straightforward undertaking. We would recognise that if that were the case, many of the challenges that set out in this report would have been done many years ago. Nonetheless, it will remain a key part of our work and commentary.
Thank you. Could I just ask, in your opinion, are there any priorities the Scottish Government should actually put forward in terms of recovery and reshaping the health service? Would you be able to say what priorities you feel should be here?
Stephen Boyle.
Well, I think I'm mindful about it ultimately for policymakers to decide on what the priorities will be. But in the event that there is consensus, I think we would return to, and again have signalled through our own forward work programme, that we'll continue to monitor the progress around health and social care integration and the extent to which, as we change the way that we think about health and social care away from the large hospital environment to it being around closer to home, more homely settings, and that all of that is factored into it. And again, we've also stated that we'll be looking closely about the extent to which progress is made around tackling inequalities within the country, referencing the progress and reporting of that too through the National Performance Framework. And then that all features in our work that we'll look to take forward over the next year and beyond.
Yeah. Thank you for that. That's certainly when we did our inquiry with the general public, they preferred to see services closer to home rather than having to go to the big hospitals as well. So that sort of gels with the inquiry. And we're talking about workforce planning reform. Do you or have you been able to identify any specifics in that particular aspect?
Stephen Boyle.
Paragraph 57, we refer to the need for the wider thinking around what that means for the workforce in terms of health and social care. We're very closely following what might come of the Feely report on the independent review of adult social care, whether that signals a very significant change for how health and care services are structured in the country and what that will mean similarly for the workforce. We do think there's a real need, though, of the integrated health and social care workforce, that there's a clear plan, that it's flexed, that it's monitored as necessary to deliver upon the ambitions of health and social care integration. So again, that features very prominently in our thinking and our work as we move forward.
Thank you. Just the last question there, Convener, and thank you. Basically regarding the staff who came through this pandemic, and obviously they've had a lot of pressure and stress. Have you identified any long-term planning to support the staff who have came through this particular traumatic time?
Stephen Boyle.
We of course recognise that the pandemic has been an incredibly challenging and difficult period for all of our health and social care workers. We make reference in the report, and colleagues may wish to say a bit more about the extent to which the well-being of the people has been supported, the well-being of health and care workers, and Eva may wish to say a bit more about that. We'll continue to track that about the because I don't think we know the answer yet. I suppose is where we're at, is what the long-term implications might be, the extent to which stress, anxiety, the trauma even of having dealt with not just one wave but now two waves of a pandemic. And I think it will be a period yet before the NHS and the government are able to form an assessment of what the implications might mean. But Eva may wish to say a bit more about what we've seen about the extent of supports that have come through thus far.
Eva Thomas Tudor.
So we've mentioned in the report about the National Wellbeing Hub website being launched, and we've seen that that's had quite good response. About 50,000 people had visited the website by December. There's also a helpline and a Wellbeing's Champion network that were launched during the pandemic. We also make a recommendation in the report that the Scottish Government and NHS boards should monitor and report publicly on the effectiveness of those measures that have been put in place to support staff wellbeing, to make sure that sufficient progress is being made.
Thank you. Thank you very much.
Thank you. Now call Brian Whittle.
Thank you, Convener. Good morning to the panel. Just good morning. I was just interested here, just to follow on from Sandra White's questions there. I think one of the things that has come to my attention, really to the attention of the committee, is that COVID really has highlighted where the weaknesses are in the system, and there is that need to reform and renew the way in which the NHS delivers its services. So I think in the first instance, can I ask how a renewed look, if you like, at an integrated workforce plan could better incorporate sort of new priorities for the NHS based on staff engagement? How do we make sure that the staff engagement is to the fore in any kind of reform?
Stephen Boyle.
It's a very important point. Ultimately, given the scale up to which staff represent the delivery of services, the cost of the NHS, that engagement with staff, their representative bodies, is an essential component of an effective workforce plan that connects with the overall strategy and the strategy of Re-Mobilization. I'm not sure we have the detail of the extent to which those conversations have taken place. And I think with all of the activity going on at the moment, focused around preventing the NHS become overwhelmed and delivering now of the vaccination programme and seeing through this next wave, I anticipate that it will be over the course of the summer that the thinking moves significantly into what Renew and Re-Mobilization looks like. But we'd agree with the point that Mr Whittle makes that staff engagement is an essential component of a well-structured, well-developed workforce plan.
Brian Whittle.
Thank you. Yeah, I was interested. I'm going to try and amalgamate two questions here, if I could. I was listening to Mr Boyle talk earlier on around the preparedness, around the exercises that I had undertaken, and maybe the lack of preparedness, if you like, and offer my analogy that we all know that an asteroid is going to hit the Earth. You just hope it's not going to happen in your watch. And I think, I just wondered whether you thought that was probably something similar to what's happened with the government here, is that we knew somewhere down the line there was going to be some kind of viral infection as COVID. We just hoped it wouldn't happen during their watch. And moving on from that, I think the question should there be, how should frontline staff be involved in sort of future pandemic planning then to ensure that it's enacted?
Stephen Boyle.
I think the fact that there were 3 pandemic preparedness exercises in the 5 years before 2020, I think demonstrates that it was part of government's thinking and activity around what risks might be coming down the line. I think the point you make is that it wasn't as a presenting issue as some of the other risks that government faces on a day-to-day basis, but that nonetheless, our analysis suggests that had the recommendations that came from those exercises been implemented, then the government might have been better prepared to deal with what presented in March of 2020, that there were recommendations around the extent to which our care homes were prepared, and also around the use and availability of PPE. So what we effectively draw the conclusion, Mr Whittle, was that there were opportunities therein to be better prepared. And we absolutely agree that the experience that NHS and social care workers have gone through needs to be captured, reflected in all of our thinking and preparedness and planning for the future delivery of health and social care services. That the extent to which staff are engaged and have opportunity to share their experiences will be a really important part of what that means for the future.
Brian Whittle.
Thank you. I also, just as I'm wondering, I've looked back at the sort of potential sort of SARS, if you like, in 2004, where there was this headline of 50,000 deaths likely from it, and actually which didn't actually come to pass. I wonder whether that has coloured judgment, in pre this pandemic. But if I could ask the question, how should the government engage the public in the new priorities. And I'm always have a caveat to that because engaging the public, I always think, you don't know what you don't know, and perhaps there'd have to be some kind of information, if you like, sort of prior to engaging the public.
Stephen Boyle.
I'll maybe I'll take your first question in terms of SARS or MERS. So it's true that there had been pandemic events during the 21st century. But predominantly those, as you say, had been in Asia and hadn't reached the UK. So I don't know whether that had led to any kind of thinking. I'm not able to draw any conclusions around that. But what we have seen through the extent to which the Scottish Government was prepared, that most of the thinking had been based around a potential flu pandemic scenario, as significant as that may have been. Whether that led to us being kind of less prepared than we might have been, I think we point to the fact that there were recommendations from those reports that hadn't been fully implemented, and draw the conclusion that we may have been better prepared had they been so. In terms of options for engaging the public, and your second point, I'm maybe not best placed to answer to how that would best be done. We would recognise recent innovations around citizens panels and so forth as an opportunity to engage the public on the development and implementation of new policy ideas, and seeing some of the reporting from those around climate change and so forth. But I'm sure the members will be better versed than I am on how best to do that. But I would agree with the fundamental point that if we are changing the nature of health and social care services as fundamentally as has been indicated from the Re-Mobilization and Renew, that it's very clearly a matter that we all care about deeply, about what health and social care services mean for ourselves and our families, and one that the citizens and the public would want to be actively engaged in.
Brian Whittle.
Thank you. Just one final question, Convener, if I may, and it's around the sort of staff turnover at executive level. Note within the report that it's been pretty much a feature in recent years. It's been quite high, and I wonder how that sort of turnover is going to destabilise, has the potential to destabilise any plans going forwards, and whether there's some sort of reflection or insights into what might happen in going forward.
Stephen Boyle.
We draw a clear conclusion in the report that the NHS and health leaders, there needs to be stable leadership. We point to probably quite a surprising volume of change at senior executive level and board chair in recent times, and even turnover within the Scottish Government Health and Social Care Department itself at senior positions. So we would agree that there's a need for stability of leadership in order to deliver the change that's coming after the pandemic, and also to steer us through the pandemic, both on a national level and a local level. So it's important to think that government itself is thinking about the extent to which it manages that change, it supports its new leaders in those positions so they're better able to discharge the very significant responsibilities they have.
Thank you very much. And now call David Stewart.
Thank you, Convener, and good afternoon to the Auditor General and to our other witnesses. Auditor General, I was struck by reading your report, if I can just quote one aspect. It said, it's not yet clear how the pandemic will develop over time and what level of spending will be required to respond, and what additional funding will be made available to the Barnett consequentials for 2021. My questions focus around there. The first is around additional COVID spending to boards. You will be well aware that the funding mechanism wasn't the normal NRAC funding formula. It was basically as required in emergency very quickly, and seemed to me to be demand-led. Is it too early for you to assess the effectiveness of that different formula for spending? And if it isn't too early, will this have implications for NRAC formula itself in the future? Whilst I accept that's a policy question, in terms of your audit role, is there a better way of doing this that's more effective for health boards?
Stephen Boyle.
Yeah, there's a number of facets to that. A key part of our work during 2021 is what we're referring to as following the pandemic pound, which is making judgments through the work of on a national basis and also for local auditors through the annual audits of NHS and also through the work on integrated health authorities. It's the extent to which money has flowed and how well that money has been spent. What it means for any changes in the NRAC formula, the kind of wider redistribution of health funding, you're right, will be a matter for policymakers to determine. For our own work, though, and particularly thinking about what that means for our NHS overview report in 2021, we're thinking about it really carefully and reporting. Because you're right, it's been a very unusual year. You know, the committee will be familiar that typically what you've seen up until now is that individual NHS boards have been facing financial challenges and the use of brokerage facilities from government to support the financial position. But the government took a clear position during the pandemic that everybody would be fully funded to deliver services, as you say, Mr. Stewart, on a demand basis. Whether that position holds and becomes a new normal, or we'll revert back to the 3-year medium-term financial plan and its associated savings and so forth, is one that we'll continue to track and pick up during the course of 21.
David Stewart.
Right, thank you. That's very helpful. Just moving on then to Barnett consequentials. Over the period that we are talking about, both for COVID and non-COVID spending, are you convinced that all the additional Barnett consequentials were passed on by the Scottish Government to the NHS social care in Scotland?
Stephen Boyle.
I'll invite Eva, I think, I suppose maybe leave his colleagues can decide who's best placed to answer, but if that's the case, that's our understanding, Mr. Stewart, is that Barnett consequentials have flown through to NHS services in Scotland on a consistent basis. And I think we draw a couple of figures in the report that the projected additional spend requirements arising from the pandemic as at forecast end of year was £1.7 billion, but the £2.5 billion in the round was available to support that funding. So we don't think that there's been a shortfall for the delivery of services. And I think it goes back to your earlier question that this is being done on a demand basis, as distinct from that there is money that's being held back. But I'll just invite colleagues to say if there's any updated understanding on that point.
Eva Thomas-Tidrow.
Thank you, Auditor General. Yeah, just to say it's a moving picture. So in the report, we stated at the point in time what the situation was. Since then, further consequentials have been confirmed. At September, the Scottish Government confirmed that any consequentials based on spend for health in England would be passed on for health in Scotland. At the moment, 2.9 billion has been allocated so far for the health portfolio, and 3.7 billion in health resource consequentials have been received. For 21-22, what we know so far is that the UK government has confirmed 719 million in consequentials, but that's quite a limit. That relates to quite a limited range of spending. So that includes PPE and test and trace, but the government expects further funding to be announced in due course. At the moment, the Scottish Government's initially committed to 869 million in COVID funding for next year, which is the 719 million confirmed from the UK Government and an additional 150 million to reflect the expectation that further funding will be made available.
Thank you very much. David Stewart.
Thanks. There's a lot of telephone book numbers being thrown around there, but I suppose the point I'm making is while there might appear to be a gap, there will be a lag in spending because government will have plans, so it won't be fully spent at present. Is that the point you're making in simple terms?
Eva Thomas-Tidrow.
Yeah, essentially.
Right.
David
Thank
Stewart.
you. Can I move on to another area then? Do you foresee any challenges in the audit of additional spending in the current financial year for both health and social care? And if so, how do you intend to approach the audit in future years?
Stephen Boyle.
So I think what was very stark is just the scale of additional spending that's taken place. We've done some initial analysis, Mr. Stewart, on where that money's been spent. What we said at paragraph 62, that money's been spent on PPE, the implementation of a COVID testing regime, and then additional bed capacity. So we'll continue to monitor and track where the money's been spent. NHS Board's financial reporting arrangements have largely remained consistent. So we'll be clear through our work, which is built up through the audit of the individual health boards and consolidated through onto the NHS, that we've got mechanisms in place, and the audits have continued during the course of 2020 and beyond. So we'll monitor that in our usual way. What's very important through our work is that, just given the scale of additional monies that have come, absolutely to the provision of health and care services, but more widely, and we've seen some of the economic support arrangements that have been put in place too, is that's clear how well that money's been spent. So we've got a detailed programme of work that will report during 2021 on how well that money's been spent.
David Stewart.
And thank you for my final question. Obviously, we're looking generally at a remobilisation and reshaping of the NHS in the future. And we've got existing performance standards which are well known and well understood. Should these performance standards be changed in light of the massive impact that we've had with the pandemic? Or does the structure right, it just needs to be fine-tuned?
Stephen Boyle.
It's a really interesting point about the extent to which these measures are measuring the right things, the extent to which they're influencing behaviour. And I think ultimately be a question for policymakers and government to decide, are these sufficiently measuring outcomes from the use of public money as distinct to inputs and outputs, that we move beyond those latter 2 points and can say, well, I go back to some of the earlier conversation of this morning about if we're spending 50% of the Scottish budget on health, that we can reasonably track what that is meaning in its widest sense for outcomes. And for us, that's a really important point. So not certainly to stray into policy terms, but particularly for us, and from an audit perspective, that we're able to say publicly what is being delivered in its widest sense for the investment of public money, and that's much more outcomes focused than it's been in recent times.
Yeah, thank you.
Thank you very much. And Emma Harper.
Thanks, Convener. Just to pick up a final question, I suppose, about new indicators and how do we measure and how do we look at existing standards and whether they should be replaced with the national performance framework outcomes, for instance. And just on the back of that, also, the last year for COVID has massively impacted health and social care, acute NHS, primary care, care homes. We've now got all the testing of care workers. And the models of care homes varies as well, where we've got the council-run versus private care homes. Some are small, some are medium-sized, and some are really large corporations looking after our older persons. So when we're trying to assess all of this and audit the performance, should we be looking at different national performance framework outcomes potentially to replace existing standards?
Stephen Boyle.
So it's a complex picture. You're right, and the various the wide range of scale of entities that are delivering health and social care comes into that thinking. And I think particularly, I'm sure the committee team will be tracking about what happens on the back of the independent review of social care, what that means for any changes to structure. I think in its simplest sense, though, is that indicators are set that are meaningful, that they drive the right behaviours, and fundamentally that they are on an outcomes basis, that we can all track what we're getting for a very significant investment. I think it's probably a case of that it's not necessarily one nor the other. of ditching all of the current indicators and moving to an entirely new set. And I think particularly we make reference in the report around the importance of transparency, and that in the context of the backlog and the remobilisation of services, that if we're on, that all of us who are accessing health and social care services can be clear as to when we're likely to access. So all of it matters, and it'd be for but more fundamentally moving to that latter point about its outcomes, and we can track that accordingly, and for policymakers to come up with a suite of indicators that allows themselves, parliamentarians and the public to have a more rounded sense of what we're getting for a very significant investment.
Emma Harper.
Thanks. Just a final question from me is Audit Scotland well prepared to audit services for best value and quality on the basis of outcomes? Is it advising government on appropriate measures and evaluation strategies?
Stephen Boyle.
So I'm clear that we wouldn't stray into that territory of advising government. I think we are independent and of government in terms of our work. Our work in terms of best value is expanding. So the statutory duty of best value is on local government bodies, and through the work of the Accounts Commission, we are developing an expanded approach to the work of best value and exploring that into the context of integrated health authorities. And that's something we'll be rolling out within the next year or so, so that our work can comment in its round and sense about the delivery of social care services and how those are being applied. So we keep our methodologies under regular review and thinking about how best to make sure that we are operating to best effect, but outcomes remains a key part of our thinking, and will continue to do so through the delivery of our work programme.
Thank you very much. And a final question on the final section of your report, Auditor General, where you touch on hospital-acquired infections and on antibiotic resistance, which is clearly something that World Health Organization has expressed concerns about worldwide in the context of the current and future pandemics. Do you believe the measures in place to address and to monitor these risks are adequate, and if not, what should be done about them? Stephen Boyle.
Thank you, Convener. I'll probably pass to Eva to answer this point. She's done much of the analysis on this point.
Eva Thomas-Tudor.
Thank you. So we haven't actually done a lot of detailed analysis on the measures that are used to monitor healthcare acquired infections. We have essentially used the ARHAI data to do that analysis, so that they'd be the ones better placed to answer what's being done around that.
Thank you very much, and thank you very much for your evidence today. Stephen Boyle, Lee Johnson and Eva Thomas-Tudor, much appreciate your input, and I know the ongoing engagement of the Health and Sport Committee with Audit Scotland has been certainly valuable from our side over the last 5 years, and I'm sure we've seen some of our recommendations also reflected in the priorities that Audit Scotland has set too. So I know that's been a fruitful collaboration, and long may it continue. Thank you very much. We will now move into private session on a different platform, and for the moment I suspend this.